Thank you very much, Carl, and thank you all for the chance to spend this time with you. I'm excited to be with you. As Carl mentioned, I just came from London, where there were 3,000 people gathered for the 20th Annual International Forum on Quality Improvement and Safety in Healthcare, which is co-led by the organization that I used to be executive of, the Institute for Healthcare Improvement and the British Medical Journal. It's very exciting to see people gathered there, but it's equally exciting to see you here. I have many colleagues in this country, and they have kept me informed through the years of the amazing work that's going on in Denmark to make your healthcare system as good as it is, and it is terrific. I'm excited that leaders like you are willing to think about how to make it even better. And in the short time I have with you, I'd like to speak with you a bit about the underlying principles, the theory of improvement as I understand it and have studied and practiced it for now 30 years, and how it might apply to a nation like yours that's trying to pioneer. I will say that we need pioneers. The world is struggling now, both the developed and the developing world, around how to make healthcare truly meet social needs. The needs are changing, they're urgent, and we currently don't have that many examples around the world of systems that are able to function at the highest possible level of performance to serve their societies. As I watch Denmark, think about the decisions you're reaching, about the next steps for evolution of your healthcare system, I would like to just tell you that the world needs you. The kind of possibilities here for pioneering with proper design and leadership and support for healthcare that truly meets population needs, the possibilities here are immense, and you could emerge as one of the great examples in the world of the kind of redesign we need. That said, I want to be a little bit careful about the advice I offer. I come from the United States. I've worked in that system for many years. I've worked in many other countries, but as you may know, the United States healthcare performance is in difficulty. Our system is far more expensive than yours, and our levels of defect, what's going wrong, are certainly the same or worse than yours. So it's a little bit arrogant for me to come from that country and try to teach you something about what to do, but you've asked me to share my views, and I will do that. My talk is going to talk about the context, why change is called for. It's going to talk a bit about aims, which is what could be accomplished in the next wave of the development of healthcare, and the principles that underlie proper improvement. I'll also suggest to you some next steps that coincide with some of the things you're thinking about in terms of your public policy. As I said, nations all over the world are struggling with a set of challenges that are not particularly new, but they've increased in their severity. Everyone's worried about the graying of society, the aging of society, the burdens of chronic illness and frailty and just caring for elders that is coming with the aging of populations throughout the developed democracies. Everyone's concerned about cost. My country's costs are a lot higher than yours. We're at 18% of gross domestic product. You're at 11. But nonetheless, even in countries at 10 and 11 and 12% of gross domestic product, you're worried. I've worked a lot in England, which is at 10.5% of GDP, and they are struggling with how to get new efficiencies, new levels of opportunity to use resources, public and private resources, for other than healthcare. We understand, I think, in all countries that we've underinvested in prevention and the upstream management of creation of health, not just healthcare, but health. And if you've ever studied even the slightest bit of epidemiology, you know that what determines your health is not healthcare. Healthcare is what determines your health is 50% your genes, but the other 50% is divided between healthcare, which is only 10%. 40% of the variation in your health is determined by things that cause illness, like what we eat, how we exercise, environmental concerns, poverty and injustice, inequalities. Those are the real generators, and we're underinvested in all countries in actually moving upstream to prevent illness. Patient safety has emerged to the fore as probably the primary concern now for most healthcare systems. That's because we have very good data on levels of injury in healthcare. People get hurt by care. It's nobody's fault. It's not that somebody's trying to hurt them. But we never designed healthcare for the kind of levels of safety of the airplane that brought me here to this meeting. That airplane is engineered to have things go right at parts per million, parts per 10 million. Healthcare fails at the levels of parts per 10, and that concerns us, and we're seeking for better designs. Person-centered care, the kind of thing you're considering with your movement towards citizen-oriented healthcare, is very modern. It's the way most systems are trying to move right now. And we're also dealing with infrastructural opportunities like transparency, new data systems. What I'm saying is we're all in this together. There are countries all over the world trying to figure out how to make healthcare serve needs better. As I said, cost is the lead, and I want to show you the US profile. I had a little bit of a foray into politics in the past few years. I ran for governor of my state in Massachusetts. I didn't win, but I got to see a lot about the public policy arena and public budgets. This is a picture of expenditure by the government in my state, Massachusetts, over the past 15 years. What you see here is that in adjusted dollars, in constant dollars, every single line item is down. Parks and recreation funding is down 25%. Higher education funding is down 30%. Local aid, which supports schools and local roads, down 40%. There's only one item in the budget, in the public side, that's gone up in 15 years, and that's healthcare. It's up 61%. On the private side, the same is true. We want our organizations, our companies to be competitive. We want our laborers to be able to take money home in their pocket. In the past 2 decades in my country and in many other countries, all of the economic growth has been siphoned off, a lot of it, into healthcare. So healthcare is sort of confiscating opportunities from other sectors by not keeping its costs under control. You might think, if you haven't studied, that this is good, in some ways good. Healthcare is a wonderful way to spend our money. It provides us with vitality and a chance to live long lives. But actually, that's not quite the case. This is a study that I published in 2012 of levels of waste in healthcare. This is a study in the American healthcare system, but I guarantee that numbers like this apply in every Western developed healthcare system I've looked at. If you look at ways that we add non-value added expenditures in healthcare, there are a lot of them. This analyzed 6 sources of waste. Overtreatment, that is doing things for people that can't help them. Giving them an antibiotic when they have a virus infection, for example, or doing surgery that has no evidence behind it. Failure to coordinate care, where people with chronic illness don't get handoffs properly. Failures in delivery of care, such as patient safety threats. Administrative costs, burdens like paperwork and inspections and redundancy. Excess pricing because of failure of competition. And fraud, abuse. If you, just in these 6 categories of non-value added activity, my colleagues and I at RAND Corporation documented 34% waste in the system. 1 out of every $3 spent doesn't add value to anyone just in these categories. I definitely don't know the figures in Denmark. You could find them out, and I would urge you to keep this conversation alive. The point is that this growing investments in healthcare may not have behind them the actual additional value that we expect. Instead, we're wasting. So we want to make things better. All countries do. And the question that I want to spend the bulk of my time is, how do things get better? What do we understand about the way that very complicated enterprises actually improve what they do? How do computers get better all the time? Why are automobiles today so much safer and more reliable than they ever were before? How come that airplane could get me here with virtually no risk whatsoever? This comes from modern investments in improvement. That's what my career's been about. How do things get better? And I'll tell you, if you want to improve, there are 2 essential elements to it. It's rather simple. The first is aim. Nothing improves by accident. You have to decide to make it better. I won't learn Spanish unless I decide to learn Spanish. My marriage won't be happier unless my wife and I decide to try to make it happier. Aim. And the second thing is method. If you play golf and you want to get better at golf, you've got to have a method of improvement. The same is true in healthcare. And I'm going to talk to you a bit about aim and method. Aim, we have a lot of help with throughout the world. In my country, the big turning point happened at about 1999 to 2001, because the National Academy of Sciences in the United States, a very prestigious scientific group, issued 2 reports that laid out aims for improvement. The first was a study of safety and injuries in care. This has become one of the most important reports ever issued in healthcare in my country, and it was called To Err is Human. And it documented that we have a major problem with people being injured in care. In my country, the number was between 44,000 and 98,000 people a year die in care, not from their illness. These are mistakes in surgery, medication mishaps, infections that they got when they came in a hospital. This makes, by the way, errors in care, injuries from care, the fourth most common cause of death, more than breast cancer, more than AIDS, more than automobile accidents. That was a pretty serious warning, a shot over the bow in my country about a major issue that really had lain pretty much hidden. That report was followed 2 years later by a more comprehensive report called Crossing the Quality Chasm, which has become the chartering document, not just in the US, but in many countries for working on better care. It said, like the first report, safety is a big issue, patient safety, but it added 5 other goals for improvement. The second goal was effectiveness. That's making sure that care matches science, that you get the benefit of science every time you enter the care system. The third goal was patient-centeredness, which you're exploring in a thrilling way now in the conversations you're having right in this meeting. Timeliness was the fourth goal, the reduction of delays that are not instrumental. We don't want waiting, but there's waiting in the system. Efficiency is the reduction of waste, and equity in my country is closing racial gaps in health status. So unfortunately in the United States, it's still true that people of color don't have health status or length of life at the same quality, the same length as people in the majority white people, and that is a quality issue. These reports were astoundingly important in the United States. They began to raise awareness and alertness in the public and the professions about an agenda for making care better. But they turn out not to be enough because the Crossing the Quality Chasm and the safety report didn't really address 2 other important factors in the performance of a care system. And in 2007, 2 colleagues of mine from the Institute for Healthcare Improvement, Dr. John Whittington and Tom Nolan, produced a model which has just swept the world. There's hardly any country you can visit now that isn't using this vocabulary. They referred to the goal set as the triple aim. The triple aim is this. Everything I just told you about the experience of care, safety, effectiveness, patient-centeredness, timeliness, efficiency, equity, that's about better care if you're in the system. If you had a heart attack or you break your arm or you're going for a checkup, experience of care. But Nolan and Whittington said there's 2 other goals that are definitely important. One is not to get sick in the first place. It's population health. It's to reallocate our energies and our thinking upstream so that all those causes of the heart attack or the broken arm or the depression or the infection can be dealt with before they ever happen. Population health was the second goal. And the third goal was to achieve population health and better care while reducing the per capita cost. That's what society needs. In my state, roads and bridges and schools and parks, they need the money. It isn't all the entitlement of the healthcare system to keep it. And what Whittington and Nolan set out was a much bolder goal than even the Chasm report had suggested, the triple aim, better care, better health, lower cost. If you come to America now, or many other countries, or came to the meeting in London, you'd see a conversation underway about the triple aim. In England right now, for example, the new head of the National Health Service, Simon Stevens, just 6 months ago put out a 5-year plan for the National Health Service in England. They call it the 5-year forward view. And although it doesn't exactly specify the triple aim, it's a triple aim plan. There's a whole set of goals around better care, safer, more effective care, a whole set of goals around population health and a rebalancing toward public health in government expenditure, and very bold goals for dramatic cost reduction. In that case, out of a $100 billion system, they intend cost reduction of around 100 billion pound system. They intend cost reductions of about 20 billion pounds. So that's the context. A set of social needs unmet by healthcare systems in virtually any developed country in the world. So why don't we fix it? Fixing it is hard. this is a metaphor I've used in speeches. I just want to explain it to you. It's a picture of a bridge in Honduras, the Central American country of Honduras. The bridge crosses a river called the Choluteca River. And as you can see, it was built in 1938. It was built very strong. It was built by the leading bridge company in the world. It was built for quality because Honduras has terrible weather and bridges are threatened all the time by the weather. And indeed, the Choluteca River Bridge got hit very hard by the worst hurricane on record. It was called Hurricane Mitch, and it hit Honduras straight on. And it destroyed things. It destroyed lives and houses, and it took down 150 bridges. But the Choluteca River Bridge didn't fall down. It stood. There was just one problem. The river moved. And so in Honduras now, there's a very strong bridge in the wrong place. This is American healthcare. And maybe a little bit in Denmark. What this means is that first bridge, that's the bridge of technocratic, hospital-based, majestic, miraculous care. I'm a pediatrician. When I studied pediatrics, every single child who I saw who had leukemia, acute lymphoblastic leukemia, died. Some died in my arms. There was no cure. By the time I was through with my training, they all lived. And that wasn't done easily. That was done with serious investment in bioscience and technologies that brought to bear on these children, and now it's a miracle. They live. That's the first bridge. That's the bridge that fixes hearts. It's the bridge that gets people through cancer. I firmly believe that all of our countries at the level of economy we're at can afford that first bridge. We need to keep providing the technocratic care. But the need has moved. The need is chronic care management. It's integrated care. It's flow of care. The need is prevention so people don't get sick in the first place. The need is behavioral health care, which coincides with physical health care all the time. The need is to work on sectors of suffering that first technocratic bridge can't meet. That's what countries are struggling with, how to rebuild a healthcare system that can actually address the profile of need, especially around chronic illness. Now, you in Denmark seem to be about to leap to the front. When I've read the proposed plans around a citizens' healthcare system, what I see is the new bridge, one that is highly sensitive to what people feel at home, in their hearts, in their lives. You say you want to create a healthcare system where citizens, patients, and relatives feel that their knowledge and needs and preferences are at the heart of treatment and caring and rehabilitation. The aim is to continually improve the quality of that treatment, as well as constantly improving the outcomes experienced by patients. I love this wording. Our focus is to make sure that the life citizens want to live outside the healthcare system, where they spend most of their lives, is given thorough consideration inside the healthcare system when courses of treatment, caring, and rehabilitation are planned. To me, spending 30 years working on improvement, to see words like this in the shared plan of a nation, municipalities, regions, private sector, physicians, it's thrilling. This is where healthcare needs to go. This is the second bridge, because if we get in touch with what people really want and need, we'll begin to get the specifications in mind for a system that actually meets them where they are, not where we start. So I told you, it's aim and method. These aims are proper. The aims will help solve a lot. Let me tell you one research study you may not know. A professor, Annette O'Connor, who was the head of a research center, a Cochrane Collaborative Center, on shared decision-making. These are technologies that allow people in care to really get their preferences expressed and to have the care adjusted in light of those preferences. Annette O'Connor did a meta-analysis of the effects of shared decision-making on patterns of surgery use. What she found was stunning. When shared decision-making is used in care systems, and it has been experimented with, total amounts of surgery fall 23%, with better outcomes for patients and more satisfaction for the clinicians. It all coincides. When people actually have control of their care and their futures, when they're actively in the dialogue instead of being dealt on, they're dealt with, things get better. And so you're in exactly the right place. I encourage you as leaders, whatever level you're at, federal government, regions, municipality, individual physicians, leaders, get on board. That citizens' healthcare idea I find thrilling. You're pioneers. Nobody knows how to do it. It's not been invented before, but you can invent it, and I encourage you to do that. So the aims are right. They're great. You're in the right place. The problem is how. What's the method through which to achieve transformation, the new bridge, the citizen-directed care, the idea of a system now fundamentally focused on the needs of people? And here we have a really serious problem. It's global, and it is really underestimated. Let me tell you what the problem is. When you're set about to improve something, and you ask, how shall I do it? The first answer, the answer that's around us, is called reliance on inspection to improve. And here's what it looks like. On this diagram, I've drawn frequency distribution of some quality. What the quality here could be operative survival rate for surgery, or it could be infection-free hospitals. It could be patient satisfaction level. Any quality level you care about. It could be in any other industry. It could be kids succeeding in school or not. Well, if we have a population of people trying to get the job done, like all the doctors in Denmark or all the hospitals in Denmark, you're going to get a distribution. It's going to be bell-shaped. That's how the world works. And reliance on inspection means that the plan for improvement is this. You draw a minimum standard, a standard that you'll regard as acceptable, and you find everyone that doesn't meet the standard, and then you do something. You shoot them, or you educate them, or you fire them, or you put them on some kind of program. It's culling. It's searching through a system for the problem and then acting on the problem. It's everywhere. It's the modal way we deal with most situations in our society, not just in healthcare. Reliance on inspection is seductive. It's satisfying in a way because you do something. It has some apparent logic behind it, but it is wrong. It doesn't work. We know that from a century of development of approaches to quality improvement, not just in healthcare, but in many other industries. What reliance on inspection does do is produce what Bill Schirkenbach, a scholar at General Motors Corporation in 1950, called the cycle of fear. The inspector comes in, and the first thing that happens is everyone inspected gets frightened. Why wouldn't they? The inspector shows up. So the workforce or the children or the hospitals, they get scared, and the reactions are inevitable. First thing they do is they fight the messenger. If you work on quality assurance, you don't get invited to parties. It's a negative undertaking. I remember I was in charge of inspection in a large American healthcare organization before I started IHI, and we produced these wonderful league tables of satisfaction levels with doctors. I was so proud of it. We used modern surveys of patients, and I was able to go into a group of doctors and show them, every doctor by doctor, their satisfaction levels of their patients. And I remember the first time I did the feedback. So I walked into the room. Every doctor had his or her report in front of them, and I'd highlighted their name. I didn't have their names on it. It was Dr. A, Dr. B, Dr. C, Dr. D. But if Carl was Dr. C, he would get a highlighted yellow line on his report showing who he was. I was so proud of this. And I started to talk, and I couldn't get through my first sentence because a friend of mine, a doctor I worked with in the back of the room, Carol Zuckerman, she stood up, she took her piece of paper, she walked up to the front of the room, she rolled it in a ball, she threw it at me, and she walked out of the room. And I was vice president of the organization. Another time, I was giving feedback reports to radiology departments, x-ray departments on waiting times. And they were terrible. We had 7 centers that operated at that time, and the waiting time for x-rays was awful. It was like 40 minutes or 45 minutes. And every month I gave the new report, and then suddenly things got better in one of the centers, the Kenmore Center, where I worked. The waiting time in May was 2 minutes, 50 minutes, 40 minutes, 60 minutes, 2 minutes. I waited. June, 2 minutes. July, 2 minutes. they had just broken through to something new. And I went over to the center and I spoke to the leader there. Joanne was the administrator. I said, Joanne, this is amazing. You've fixed this problem. How did you do it? She said, Don, it was really easy. I lied. She said, I made it up. I said, Joanne, how could you do that? She said, well, I thought you'd be happier. She said, I knew I'd be happier. Because when you send that report, it goes to my boss's boss's boss. He circulates the number in red. He sends it to my boss saying, do something about it, or sends it to the boss. It goes around, then it comes to my desk saying, Joanne, fix it. As if I weren't already trying to fix it. As if I didn't already know it's a problem. She said, you waste my time. That's the cycle of fear in work. The consequences in policy, when this gets into the marrow of an organization or a country, are destructive. Measurement goes wild. Because you have all these games going on, you have to measure more, not less. And the industry of measurement rises and rises and rises until finally no one knows what's going on. There are so many metrics and so many things going on. Life becomes unorganizable. The concept of accountability itself, it chills dialogue, it chills exchange. The conversations become inauthentic. The worst thing we're doing in the United States right now is getting patients to have skin in the game, increasing their accountability by raising their costs. So now they'll be sensitive to the cost of care. No. What happens when you have patients pay more is poor people get hurt. That's about the only thing we know that happens. The concept of markets as a force for improvement, I'm willing to understand the value of markets. I'll tell you that market-based reform drives oversupply and raises cost. It does not produce improvement. We've not seen that. So we have a problem. The problem is that the hegemonic system of improvement doesn't work. It's inspection-based. This is my grandchild. It's one of them. This is Nathaniel. He's 5 years old. And he's in his favorite place in the world here. He's sitting on a heating vent in my house. And he's playing with Legos. You know those things that kids put together? He'll do this for hours. You watch Nathaniel play. Oh, he'll put together a spaceship. Then he'll take it apart. And he'll build a bigger spaceship. And he'll take that one apart. He'll build a bigger one. Nathaniel, hour by hour, day by day, month by month in his life, wants to do nothing more than to build a better spaceship. He's not on an incentive program. He's not being inspected. There's no report coming to his desk. His supervisor isn't showing up. He's a person, a human being trying to get better. We all are. And I think as we think about making care better, we've got to remember Nathaniel. We've got to go back to the idea that the people, in general, they want to do well. And if our behaviors as political leaders, managers, executives, respects that on the whole and understands how we work with Nathaniel to make his spaceship better, we get better answers than if we think we have to come in with a regime of accountability and inspection that won't work. We're after continual improvement, after all. Inspection can only work on the few that are deficient. That's the whole idea. If we all want to get better, then we all have to work together the way Nathaniel works on a spaceship. It's a learning process, not an inspection process. Now, let me deepen that thought for a minute with the help of a great scholar in quality named Dr. Joseph Juran. He died at age 101 just a few years ago. Dr. Juran was a chess grandmaster and also one of the great thinkers about quality in the world. Not in healthcare. He was working on other industries, but I got to know him quite well. Juran said this. He said, well, in a complex system like a company or an organization, or I'd say healthcare, or maybe I'd even say a nation, there really are three kinds of improvement that need to go on all the time. He called them quality control, quality improvement, and quality planning. If you want to think about making healthcare in Denmark better, all three do matter. I just spent 10 minutes criticizing inspection because it's very destructive. If it's the only thing you're doing, if it's the thing you're relying on for improvement, inspection doesn't improve anything. It gets rid of the junk. That's called quality control. The problem is when that takes over the regime of the search for improvement, things go wrong. Nathaniel gets demoralized. Waste goes up. Paperwork goes up. But Juran correctly points out you need some form of control. The best controls, by the way, are local controls, not top-down. But when a workforce or a hospital or a group has the ability to notice when something is really going wrong and take care of it and fix it right locally, that's quality control in the Juran trilogy. Most of us aren't wrong. We just could get better. And that big yellow lump is the second part of the Juran trilogy. That's improvement. That's the support for everybody all the time to learn how to make things better. The learning processes, they need support. They're local. You have experts right here in Denmark who understand what improvement looks like and how to support it. I've worked with them myself through IHI. The supports are collaborative projects where everyone gets together and gets an aim together and works together with transparency and openness. They're exchanges in which it's safe to report something that went wrong because then you can learn and maybe make it better the next time. That's the improvement enterprise. The third enterprise in the trilogy is invention. It's creation, de novo and creation of the future. It's making the new bridge. Nothing to do with inspection, and a little different from improvement. A complete plan for making things better has all three elements. Just enough control, just enough improvement, and just enough invention. The invention is to invent new systems. This is the first law of improvement, I call it. Every system is perfectly designed to achieve exactly the results it gets. Your system in Denmark is perfectly designed to achieve what it's doing now with respect to patient-centeredness or safety or prevention. If you want different performance, you need to learn your way to a new system. You cannot inspect your way to a new system. That's not going to work. Inspection decreases change. It decreases motivation. It decreases risk-taking. But if you really care about creating a future, you want to increase the chance to find good examples. Now, I'll show you a few of what it can look like. This is the best. This is a system in Alaska, where I worked, called NUCA. NUCA is completely redesigned care. I think it's triple aim care. The NUCA system takes care of 60,000 natives in the Alaska natives, Indians. And it's owned by the Indians, so that when the NUCA system does its work, it calls its patients. It doesn't use the word patient. It uses the term customer owner, because that's the fact. This is transformed care. This is a doctor's office at NUCA. Believe it or not, you're looking here at a doctor's office, but there's not just a doctor in it. There's a doctor and an advanced practice nurse and a psychologist, behaviorist, and a nutritionist, and a physical therapist, and a pharmacist. NUCA is team-based care, taken as far as you could ever imagine it to be. Thoroughly integrated, thoroughly focused on the needs of the people. There are 10 principles to the structure of NUCA. You could study it. Look at the results. Transformed care. 50% decrease in A&E use. 53% decrease in use of hospitals. 65% decrease in use of specialists. 20% decrease in use of primary care, because NUCA is working from abundance. They're using the resources of communities to get health back on the screen. This is telemedicine at work. This is the ECHO project in New Mexico, an American state. You're looking at Dr. Sanjeev Arora. He's the guy with the tie there. ECHO is telemedicine coaching. Now, Dr. Arora is an expert in liver disease, and especially hepatitis C. And he knows how to cure hepatitis C, which is difficult. But he also knew that he couldn't meet all the needs of New Mexico. It's a vast state with many rural areas, and he decided he could do a better job if he could sit in his office in the medical center and do coaching of primary care clinics all over New Mexico virtually. He covers the entire state now. And through telemedicine support of nurse-led clinics, he's able to help them treat patients with hepatitis C with the same or better results as if those patients got to the medical center. This is the level of eradication of the virus. Notice the ECHO results in little towns and villages all over the state are the same as if the patients got to the University Medical Center. Better care, better health, lower cost. This is another telemedicine project. This is the PEAK project, which is headquartered at St. Mary's Hospital in England, started by 2 young ophthalmologists. They do visual retinal examination remotely through cell phone technology, getting images just as good as if the patients came to London. But these patients can be in rural Pakistan or Kenya. PEAK has now coached teachers in Kenyan schools to screen 10,000 kids per week for visual acuity. They're moving knowledge, not people. This is a new workforce design, which I think is one of the most exciting frontiers for innovation, for invention. In Alaska, where I worked, there are many, many tiny villages, and you can't send a dentist to those villages. In Alaska, they invented a new discipline. The discipline is called dental health aid therapists. They are young people out of 2 years of college, who get trained for 18 months to do essentially complete dental care. They can fix dental caries, they can do dental prophylaxis, they can do restorations. They get on a bush plane and they fly out to a village with that little machine you see there. That's a kind of pop-up workstation. And they can provide care in Alaska. With 70 of these therapists, they can meet all the needs of that vast state. It's rethinking the design of the labor force. This is rethinking the patient role. This guy's name is Christian. Christian is an engineer in Sweden. And he was at Saab Motor Company. He got a kidney disease that caused kidney failure, and he got treated in Jönköping, Sweden, at the local at the teaching hospital, Rehab Hospital. He got hemodialysis, dialysis for kidney disease. But when he got dialysis, Christian didn't stop. He said, to his nurse, Britt Marie, he said, I could do this. I'm smart. I'll be very careful. I think, Britt Marie, you can infect me, but I'm not going to infect myself. Let me do my own hemodialysis. And she did, because the hospital supports that kind of invention. Christian was right. He did it. He taught other patients to do it. The hospital took it on, and now 5 years, 6 years later, 60% of the patients in that hospital on hemodialysis do their own dialysis, do it themselves. And the results were stunning. A 50% reduction in cost, a dramatic reduction in complications, and much more pride and joy. Invention can occur in communities as well. This is a wonderful project in Scotland. It's called the Daily Mile. This is a school, St. Ninian's Primary School, where it turned out a lot of kids were obese, as they are all over the world. 45% of the pupils were in deciles 8 and 10 of obesity. And this was pointed out by a school volunteer. He thought it was a serious problem, and it is. This school took the ball. They started doing a series of tests with the students and teachers, seeing if they could get the kids to begin to run a mile a day. I'm almost out of time, so I can't give you the whole story, but they took modern quality improvement, applied it in a classroom, got the kids and the teachers running, and the results are stunning. As of now, every single one of the 420 students in that school, elementary school, are fit. And in the primary school today, not a single child is overweight. This was accomplished in less than 2 years. If you want to think about the new bridge, the care we need, think about design and redesign. Imagine a place that could build on this kind of innovation, that with a team-based care of nuka, lean production, like you're trying here in Denmark in many places. The telemedicine of the ECHO project or the PEAK project, the new job roles of the DHAT therapists, and really activated role for patients, such as you're imagining in your new charter. There is no reason we cannot have the triple aim through redesign. It will never happen through inspection. Inspection will decrease the risk-taking, decrease the willingness to invest in new things. You're just trying to make the old better. It has to be part of the system at some level, but it doesn't hold your future. But the future's here. It's just not widely distributed. And if Denmark is smart enough, as I know you are, to really begin to think about reinvention everywhere in the system, supporting improvement, supporting creativity, you will get there. You are crucial. The front line, the people out there doing the work, the doctors, the nurses, the managers, they can do this. Look at what happened in that school in Scotland. Look at the innovations of 2 ophthalmologists in England now screening tens of thousands of kids around the world. The workforce can do it, but they can't do it without the leadership. Political leadership, executive leadership, regional leadership. You've got a job to do here, which is to set up a system which can support this kind of exploration. The system has 3 elements. It's going to include development of skills and techniques. Someone has to teach people how to improve. They don't learn it. You have to bring that into the system. A culture that fosters risk-taking and innovation and excitement and joy, and a strategy that's aligned like you are around the key idea. In this case, your key idea, citizen-centered care. It's crucial. The techniques can be taught. This is the model for improvement that IHI has taught all over the world. It's what those kids were using in the school in Scotland. It's what Sanjeev Arora does now in ECHO. It just says when you want to improve, get an aim, get a measurement that can be used locally, and begin to test changes. And you can do it in a collaborative mode. You and Denmark have very good experience with collaborative improvement. You always learn better together than separately. You did a brilliant project with 5 hospitals on patient safety. There's no reason why 98 hospitals can't be involved throughout the nation in a constant collaborative learning process. But it's going to take you to help. And one final barrier here. Everything I'm describing is better, a better Denmark, lower costs, better health. You might ask the question, why don't we all go there right now? Nuka is better. This is the reason. It's the status quo. It's the stranded capital. It's the new cathedrals we've built in our hospitals. It's the thinking we have about technocratic medicine. It's a labor force that says, oh, no, dentists do dentistry. There's a drilling through here, the status quo, to new possibilities, and that's a leadership task. And boy, you could show us a lot about how to get it done. The job for you leaders is this. Don't back down from declaring the need for improvement. If you don't set the aims, you can't meet the aims. So declaring a patient-centered system, yes. Declaring a safe system, yes. Establish the need for improve and set the goals. That's leadership. Establish the metrics, not for the purpose of league tables or making people feel bad or good or rewarding and punishing. That's not the proper use. But for learning, yes. Being able to do studies and experiments to learn who's doing better. Put the patient and the care and the community, the person in the center, the citizen in the center. They'll give you the best information you can ever get, and they'll become full partners in reinvention, invited to do so. Invest in workforce development, because the workforce doesn't know from the start how to do the improvement. You've got to spend money, spend time, spend energy developing the skills for improvement, the collaborative models. I strongly urge, by the way, a fellowship system. In England right now, they're going to create 5,000 improvement fellows in a country of 40 million. Can you imagine that? That would mean no town or village would not have somebody in it who really understands how this mechanism of improvement works. Get out of the blame game, ceasing fear, ceasing blame. The foundation for excellence in a service industry is pride and joy in work. And when joy goes down, work gets worse. It's pride. And you leaders have a chance to build that in a country, especially a country of this size. I call it a learning world. We know about learning organizations, which are the ones that are winning in the global marketplace today. We need a learning world, a learning Denmark, where the leadership understand now that moving beyond the carrots and sticks, the inspection-oriented surveillance system, it's time. It's the way. I think you can do it. And I've read the documents that are on your tables. I understand a bit about where you're going. I get excited to watch it, because a country of your ethos, of your skill, of your dedication, of your achievement to date, and your size can really create the future. So do it. We need you. Thank you very much.